is we're going to look at the prevalence and incidence of atrial fibrillation, because atrial fibrillation is extremely common. So we're going to discuss the burden fibrillation on the general population. We're going to define it, show you what it looks like on the ECG or rhythm strips, go through some of the clinical presentation, and then the bulk of our discussion is going to be on stroke prevention and rate and rhythm control. So that's the management of atrial fibrillation. We're going to go over the 2014 guidelines thoroughly, because there's a 2019 update, but it is only those things that need to be changed that were addressed. So it's not the complete, prevalence, incident, definition of atrial fibrillation. So we're going to use, the bulk of our discussion is going to be on the 2014 guidelines. And then we will, at the end of the talk, we'll go over the 2019 updates, because there are some updates, and you should know what those updates are. Okay, so let's move straight into. So when we talk about how common atrial fibrillation is, it's common. It increases with age, and the prevalence in the population under age 60, about 1%. Between 75 and 84, it's about 12%. But for patients over age 80, approximately a third of those patients, 1/3 of those patients, will have atrial fibrillation. I look at my clinic schedule on a daily basis, and more than half of my patients is either they have had atrial fibrillation in the past, or they currently have atrial fibrillation. So this is a very, very common condition, a very, very common arrhythmia, and all clinicians and extenders should know how to make proper assessment of atrial fibrillation and then the management of atrial fibrillation. If you look at individuals from European descent, individual with European descent, the lifetime risk of developing atrial fibrillation after the age of 40, 26% for males and 23% for the females. So just think about it. This is more than a quarter. This is a very, very, very common arrhythmia. And again, everybody, all clinicians and extenders should know how to make the assessment and manage these patients. The thing about African Americans, though, the African Americans, they have more of the risk factors for AFib, but the incidence is a little bit lower, not tremendously lower. There are some people going around saying that African Americans don't have atrial fibrillation, so they really haven't been treating African Americans for them to be saying something like that. The incidence is a little bit less, but it's still a tremendous burden in the African American population. Atrial fibrillation is often associated with structural heart disease. So, if someone have any type of cardiac pathology, they have a valvular leak, they have valvular stenosis, they have septal defect, any type of structural disease, can somehow precipitate atrial fibrillation. So we know the mechanism of what causes atrial fibrillation and what sustains atrial fibrillation. It's multifactorial, but we need to have an understanding. Uh, just some more information, background information. Atrial fibrillation is associated with a five-fold increase in the risk of stroke. So when you look in the general population, if you have atrial fibrillation, you're 5 times more likely to get a stroke. You know, not only that, if you get a stroke, it's usually going to be a bad one. It's going to atrial fibrillation is usually more severe than if you did not have atrial fibrillation. It is also associated with a threefold increase in heart failure. So, stroke, heart failure, you know, one of the things that atrial fibrillation can do, and we'll discuss that as you know we go on. We can get what we call a tachycardia-induced myopathy. That is the increased heart rate that is associated with atrial fibrillation can precipitate a heart muscle disease. It weakens the heart muscle, okay, and you can go into heart failure like that. There's a twofold increase in dementia mortality. So, you know, it's not as benign as a lot of people think it is. If you look at the U.S. Population, United States population, hospitalization with atrial fibrillation as the primary diagnosis is close to 500,000 yearly basis, 467,000. And when you look at death, it's about 99,000 deaths per year related to fibrillation. Okay, and you know, atrial fibrillation, those patients all the time get multiple admissions to the hospital. You know, they come in with a rapid ventricular response, they're in heart failure, they're hypotensive, they're passing out, and you know, so multiple admissions. AFib patients are hospitalized twice as often as patients without AFib. So it's not a benign condition. It you know, it presents tremendous burden on the population. So we should know a little bit about it. When we look at deaths, 2.1% of deaths is related to AFib as compared to 1.1% without AFib. So, you know, more patients who die have AFib than patients without AFib. And then we look at the financial burden, because some people don't appreciate the impact of something unless you give them finances. Treating patients with AFib adds about $26 billion to the US healthcare bill annually. So this is an extremely expensive condition. And when we look at the population as a whole, it affects about 2.7 to 6.1 million, you know, overall. So what is atrial fibrillation? So we you know, we hear about this condition. It's fairly common. You know, it impacts mortality, morbidity. You know, how do we define it? How can I recognize someone who is in atrial fibrillation? So atrial fibrillation is a supraventricular arrhythmia, and so it's an arrhythmia that is occurring in the atrium. Okay, and we have this uncoordinated atrial activation. So just imagine we know the normal conduction, the SA node fires, the impulse travels through the atrium, it slows somewhat in the AV node, and then it passes on the bundle of His to the left bundle first, and then the right bundle, then the His, then the Perkins system. That is a normal conduction. with atrial fibrillation, the atrial activation is uncoordinated, and as a result of that, you're not going to get effective atrial contraction. We're going to go into the mechanism in a little bit more detail, but in a nutshell, that's what it is. So as a result, when you look at your surface EKG, when you look at the 12 EKG, you're going to get what we call irregular RR intervals. That is, your R waves, they're going to vary, and there is no pattern to the variation. And that's what we call, so we classically describe that in clinical terms as irregularly irregular, because there's no regularity to the irregularness. Okay, so irregular rhythm, and sometimes you can feel it. So when you feel the pulse, if there is no regularity to the pulse, it's all over the place, you can suspect atrial fibrillation. Okay, so when you look at the surface ECG or rhythm strip, there are gonna be absence of distinct repeating P waves. You might see some undulation, and you may be tempted to call it sinus rhythm. But remember, sinus rhythm, you're going to have regular P waves, and they're going to repeat themselves. They're going to look uniform. So atrial fibrillation, you can have these undulations in the baseline, but you're not going to get distinct repeating P waves. And again, as we said, the atrial activity is irregular. So when you look at ventricular response, it's going to be irregularly irregular. That is if you do not have AV block. Okay. So in a normal situation, again, just going over conduction pattern, the impulse starts in the SA node, and that's why we call it the pacemaker of the heart. So the impulse is generated here, and it's transmitted through the atrium, and it moves from the right side to the left side as well. It gets to the AV node where the impulse slows somewhat, and then it travels through the bundle of hairs. Okay, the left bundle first, and then the right. The is Purkinje system. So the whole heart is activated, so to speak. And this is the surface ECG that you normally get, this normal conduction. So you'll get your P wave due to atrial depolarization and the QRS as a result of ventricular depolarization, then your T wave as a result of ventricular repolarization. So this is normal ECG pattern as opposed to atrial fibrillation. And again, we're going to discuss the mechanism in a little bit more detail. But where you have the pulmonary veins enter into the left atrium, there is these wavelets that forms around that area. So you have these abnormal impulse that forms just where the pulmonary veins enter the left atrium. And you have these series of irregular activation, and it gives you a rhythm looking like this. You can see that the R waves are very irregular. There's no regularity to the R waves, and we describe them as irregularly irregular. Okay, so and if you look at the baseline, yeah, you can see the undulation looking like a P, but you'll never see anything looking at that again. Remember, a P wave tends to be repeating, and it looks fairly uniform. So this is atrial fibrillation, and most people should be able to atrial fibrillation. All right. So, what are some of the clinical presentation of atrial fibrillation? Um, so, a lot of time when someone presents with atrial fibrillation is because they have some type of hemodynamic consequence. Silent atrial fibrillation is when you have atrial fibrillation and you don't know you have atrial fibrillation. You go to the doctor for a routine checkup or clearance for surgery, and you're found to have atrial fibrillation. So you didn't have any hemodynamic consequence. So when you have clinical presentation as a result of hemodynamic consequences, is either the ventricular rate too slow or too fast. Again, remember, when you have atrial fibrillation, these abnormal activation, which starts in the left atrium, they are very, very fast, rapid. We're talking in excess of 500 beats per minute. So a tremendous firing. Those impulse travels through the atrium into the AV node. They're slow tremendously, and it's a great design. The heart was constructed in such a fashion where the impulse is slowed, because the maximum firing of the AV node is probably about 180 beats per minute. So you're not going to get much higher ventricular response than say 180 beats per minute, because those 500 beats or 500 activation that's coming from the AV is going to slow, and only about maximum probably 180 of those impulses are going to travel to the ventricle. So you can get a very rapid ventricular response, and a lot of patients will tell you they're short of breath because they're going into heart failure. They're lightheaded, they're passed out because they're hypotensive. So those are some of the clinical presentation. Again, we said lack of atrial coordination, atrial contraction, and as a result of that, you this beat to beat variability in the ventricular response, and as a result, the ventricular filling. Because when you look at your ECG, you're gonna have varying RR intervals. So that's one of the way we diagnose atrial fibrillation. The RR interval varies. If you're in the cath lab, however, and you look at a heart that's in atrial fibrillation, and you're to do some hemodynamic assessment, what you're going to see is that the volume of blood that's in the heart, that's the heart pumps out, varies with these beats. Sometimes, I mean, the heart pumps a very, very little amount of blood. Some of these, because the heart interval is so short. Okay, so the heart didn't have time to fill properly. So the heart is going to pump out varying amount of blood. So not all beats are going to be the same, and some patients can get real sick when that happens, because some beats, you have an adequate amount of cardiac output, and then other beats the cardiac output is suboptimal. So patients can feel very sick because of this variability in ventricular filling. Okay, as a lot of patients are going to be asymptomatic. That is, they don't have much symptoms. You know, therefore, some patients would tell you that they're fatigued. So that's one of the most common presentation. They feel fatigued, and it may be related to the fact that the cardiac output is going to vary from beat to beat. You know, they are if you want to be physiologically accurate, then the stroke volume is going to vary from beat to beat. So, you know, patients will be fatigued. That's one thing they'll tell you. They're fatigued. I mean, you press them or you're short of breath, and it's like just don't have any energy. So that's one of the most common presentation. You know, I don't have any energy, doc. A lot of patients will tell you that they have palpitation. That's because you have a rapid ventricular response and they feel it. You know, um, shortness of breath because the atrium is, I don't want to say it's not contracting, this uncoordinated, ineffective contraction. So therefore, the atrium is not contributing to cardiac output. And in some patients, especially some older patients, atrial contraction contributes sometimes 40% to the cardiac output. So just imagine you're losing 40% of the cardiac output. You lose 40%, you're going to be symptomatic. So patients will be short of breath. Sometimes they're hypotensive and sometimes they pass out. You know, if the ventricular response is fairly rapid, you know, the cardiac output falls tremendously. And some of these patients have syncopal episodes. And then heart failure, because again, you're not, if the atrium is not contracting, you're going to lose a significant proportion of your cardiac output. And in some patients, it's as high as 40%. Again, some patients tolerate atrial fibrillation very, very poorly. And you'll have someone who have mitral stenosis, and you know they may have valve area of 1 centimeter square, and they're doing fine. They're going to atrial fibrillation and they're in heart failure. They, you know, it stopped them in their tracks, because when you have mitral stenosis, the mitral valve is stenotic, so it's going to impact diastolic filling of the heart. When you have atrial fibrillation with rapid ventricular response, it's going to impact diastolic filling of the heart. So there are two things that cause impairment in diastolic filling of the heart. So a lot of these patients with atrial fibrillation with mitral stenosis will go to heart failure. Okay, so once someone has mitral stenosis and they go into atrial fibrillation, that is an indication to do mitral valve replacement. Okay, because that patient is going to go downhill after with hypertension, for the same thing that, you know, a lot of these hypertensive patients have diastolic dysfunction, so their heart does not perform properly in diastole, and atrial fibrillation, you have loss of the atrial contribution to diastolic filling. So some of these patients go into heart failure. Patients with hypertrophic cardiomyopathy and restricted cardiomyopathy. So some patients tolerate atrial fibrillation very, very poorly, and this group does. Okay. All right. So we come now to some terms that you have to know, because these are from 2014. So these terms have been around since 2014, and you know, when we talk about the different types of atrial fibrillation, this is what we're talking about. So paroxysmal atrial fibrillation, this is when atrial fibrillation terminates either spontaneously or with intervention within 7 days of onset. So, you know, patient have atrial fibrillation, they come in and you do an electrical cardioversion, and it's less than 7 days. That's paroxysmal atrial fibrillation. So less than 7 days. Okay, the episodes may recur with variable frequency, however. But once it's terminated within 7 days, is the definition of paroxysmal atrial fibrillation. Then persistent atrial fibrillation, which is another term that you need to be familiar with. You have continuous atrial fibrillation lasting more than 7 days. So atrial fibrillation lasting more than 7 days, called persistent. Then long-standing persistent lasting more than 12 months. More than 12 months. Okay? And then we come now to permanent atrial fibrillation. Essentially, permanent atrial fibrillation is used when the patient and the clinician make a joint decision that they're not going to do more attempts to restore sinus rhythm. I don't want you to shock me anymore. Don't do any AFib ablation, nothing. So once they come to that understanding, then we call it permanent atrial fibrillation. So you should be familiar with the different terms, and people who are doing exams, they usually like to test CNDs as well. And then there's another term talking about non-valvular AF. And whenever we talk about atrial fibrillation, we always talk about non-valvular atrial fibrillation. What is this non-valvular atrial fibrillation? So if you have atrial fibrillation occurring as a result of a valvular problem, then that's called valvular atrial fibrillation. And then all other atrial fibrillation is non-valvular. So the only two conditions that qualify as valvular AFib, and there's some updates. There's a 2019 update and this as well. But in generally, if you have mitral stenosis or mitral replacement or repair, that's what we call it. So not atrial, not aortic stenosis, not aortic valve replacement. It has to be specific. Mitral valve replacement, okay, with a mechanical or biprosthetic valve, or a mitral valve repair, okay. So and mitral stenosis by itself, as mentioned before. So these, and people who are doing an exam, they're going to test you on that. They're going to test you on that as well. They will give you a case of aortic valve replacement, and AFib, no, that's not valvular. That's not valvular AF. So valvular AF, mitral stenosis, and as a matter of fact, the 2019 guideline states that moderate or more. We go over the 2019 guidelines, but we're just going to give you the 2014 guidelines first, and then we'll do the update. So mitral stenosis, mitral valve replacement with either a mechanical or a prosthetic valve, or mitral valve repair. So those are the conditions that qualify as valvular AF. And the distinction is important because for valvular AF, those patients are at higher risk of developing thromboembolism. And in the current climate, those patients have to be treated with warfarin. You cannot use any of the NOACs, okay, the newer oral anticoagulants. You have to use warfarin for those patients. But we're going to go over this from time to time. When you have atrial fibrillation, there are usually some associated rhythm. There are, birds of a feather flock together, so to speak. So you tend to get some arrhythmias that in these patients. And atrial tachycardia is one of them. In this condition, you have discrete P waves. The heart rate is between 100 and 250 beats per minute, and the mechanism is micro re-entry or automaticity. Sometimes you have to treat the atrial tachycardia, the focal atrial tachycardia, and then you go for the atrial fib, atrial flutter, and a macro reentrant atrial tachycardia. So, all right. So atrial flutter, we you commonly go on the floor, and the nurses or even some of the doctors flutter. If you understand atrial fibrillation and you understand flutter, there is no such thing as fib flutter. You highlighting your ignorance if you use terms like that. That means you don't understand the mechanism of what's going on. Flutter is a distinct thing. It occurs. There's a little triangle that you usually get your flutter wave developing, and flutter, it usually forms in the right atrium, whereas your atrium, as we mentioned before, is where you have the pulmonary veins entering into the left atrium. There are two types of flutter, and you can distinguish them just by the heart rate. Type 1 flutter, or if you want to call it the typical flutter, where the P waves have a rate of between 40 and 340 beats per minute. And when you look in the inferior leads, leads 2, 3 AVF, you have negative sawtooth pattern. Type 1 atrial flutter. These patients are easily treated with ablation. So if you have someone with type 1 atrial flutter, you should always send them to get this taken care of, because you can ablate these patients. It's an easy procedure and they do well. As opposed to type 2 flutter, where the atrial rate is greater than 340 beats per minute. So this is your type 1 flutter. If you look in lead 2, lead 3, EF, you have these negative sawtooth patterns. It goes down. And the reason for that is the mechanism. As we pointed out before, there is this little triangle area in the right atrium, a conus tricuspid isthmus. It's a little triangular area, and the re-entry is in a counterclockwise direction. Okay, so triangular area, conus tricuspid isthmus. This is why you get these negative P waves and leads to AVF, as opposed to you can have the reverse, where the direction of the impulse is clockwise, and then the P wave would be upright in the inferior leads. And so typical flutter, type 1 flutter, get negative P wave in the inferior leads, and then when you look in P1, they're going to be right. Okay, these are the patients that are easily treated with ablation. Okay, so all right. So what about the mechanism of AFib? So we mentioned it briefly. So what most of the studies have shown is that you have this left atrial myocardial sleeve that extends into the pulmonary veins, or the pulmonary veins enter into the left atrium right at that little junction. have these um, these uh, reentrant wavelets forming the left atrium, right where you have the pulmonary veins entering the left atrium, and that's one of the current thinking, because when pulmonary vein isolation and ablation, it can treat these arrhythmias, AFib. So if you can do ablation around where the pulmonary veins enter the left atrium, you can prevent atrial fibrillation. So this mechanism seems somewhat reasonable. And so where you have the pulmonary vein entering the left atrium, you have these topic foci, and then you have these multiple wavelets, which tends to cause the chaotic activation. What are the roles of the autonomic nervous system in all of this? So we know that you have the sympathetic and the parasympathetic nervous system. The autonomic nervous system can AFib. Activation of the parasympathetic and or the sympathetic can provoke atrial arrhythmias and atrial fibrillation as well. Acetylcholine are shown to activate a specific potassium current, which can also give rise to or promotes atrial fibrillation. So what we need to understand is that when you have atrial fibrillation in itself can cause electrical and structural remodeling of the atrium. So you have the risk factors for atrial fibrillation, and the foci where the pulmonary veins enter the left atrium stimulates, and you get these chaotic wavelets. Atrial fibrillation itself, when you develop atrial fibrillation and you stay in atrial fibrillation for some period of time, it can cause damage to the atrium, which promotes further atrial fibrillation. So you'll hear term atrial fibrillation begets atrial fibrillation. That is because the atrial fibrillation can cause damage in the atrium and promotes atrial fibrillation. So again, as we mentioned, aging, one get older, the incidence of atrial fibrillation increase, environmental stress, inflammation, activation of renin, angiotensin, aldosterone system can also that. And again, if you look at this little diagram, so we have atrial structural abnormalities such as fibrosis, dilatation, ischemia, infiltration, and hypertrophy. These are the stuff that can give rise to atrial fibrillation. Again, inflammation, oxidative stress can give rise to that. Activation of angiotensin system can do that. Tachycardia remodeling. So any type of atrial can give rise to fibrosis, the dilatation, the ischemia, the inflammation, and that can set up atrial fibrillation. So these are some of the clinical risk factors for atrial fibrillation: increasing age, hypertension, diabetes, previous MI, the heart disease, heart failure, obesity, Obstructive sleep apnea is a big one. Um, Cardiothoracic surgery, patients go for bypass surgery and they come back in atrial fibrillation and replacement. Smoking, exercise, alcohol use, hyperthyroidism, increase our pulse pressure, European ancestry, remember mentioned that, family history, fibrillation sometimes runs in family, there's genetic variants. When you look at the EEG, if the patient have LVH, that increases the risk. When you look at the echo, enlargement increases the risk. Decreased LV fractional shortening, decreased ejection fraction, yes. Increased wall thickness, the echo, yes. And increase the biomarkers such as your C-reactive protein and BMP increases the risk. So how do we evaluate with atrial fibrillation? What do we do? The patient comes in, we have an emergency room on the floor. Same thing. You do any type of medical problem. You take the history, physical examination, and then you do the test that is necessary. For atrial fibrillation, you need your ECG confirmation. So, clinical history and physical examination. You develop you have to determine what type of atrial fibrillation is. Is it paroxysmal? Is it persistent? Is it long-standing persistent? Is it permanent? So you need to have a type of arrhythmia you're dealing with. What causes it? You know, there's some precipitation. So that's a big cause. Someone who had a surgery, lying in bed for 4 or 5 days, you know, develop, or they might not develop anything. The nurse might look at the telemetry and the patient's in AFib, or they may develop a little shortness of breath, the AFib. So you have to know the cause. What can cause atrial fibrillation? Is the patient hyperthyroid? That associated cardiac and extracardiac disease, and you have to determine the thromboembolic risk. Someone who have atrial fibrillation, that's one of the most important things that you're going to do, because you don't want the patient to get a stroke or any other type of thromboembolic problem. So you have to go through the exercise. How do I determine what type of risk thromboembolism patient is faced with? And then, of course, you're going to look at symptoms. So if it's someone that repeated admission for atrial fibrillation, what type of treatment they had before, did electrocardioversion work 5 years ago? If 5 years ago and they come back, yeah, you can probably, do another electrocardioversion. The family history, going to examine the patient, and when you feel the pulse, irregular. However, sometimes the pulse may be irregular because the difference in the RR interval may not be that significant. So you sometimes you're fooled. Listen to the chest though, and that's probably more accurate. Also, the variation in the intensity of the first heart sound because of the variation in the RR interval. You cannot have a fourth heart sound with atrial fibrillation. So understand, a fourth heart sound is because of atrial contraction. If you don't have atrial contraction, you cannot have a fourth heart sound. So, those of you who see patients, you do beautiful is physical, and then you say the patient have an S4. That means you don't understand what's going on. Atrial fibrillation, no atrial contraction, you can't have a fourth heart sound. Okay? And of course, your ECG, any other electrocardiographic recordings is important. That's how you make your diagnosis. Chest X-ray, you want to see patients in heart failure. You want to look at the cardiac chambers to see if they're large. And of course, echo. You have to do an echo. All patients should have an echo because you're looking for structural heart disease, looking for the function and size of your chambers. So TE, well, the recommendation is that you should be very liberal with the TEs because even some patients, I just felt this, it started 2 days ago. It may be silent for 4 weeks and they have a clot in the heart. So if you try to convert them and they have a clot in the left atrial appendage and they embolize and have a stroke, so we liberally do transesophageal echo. And the reason why we do transesophageal echo is to look for left atrial and left atrial appendage clots. The T is very sensitive and very specific in looking for clots in the left atrial and the left atrial appendage. We use it to guide cardioversion or catheter ablation. So, what we do, patient comes in overnight, regardless what kind of AFib it is. If they're still in AFib in the morning, well, they keep nothing to eat when they come in. If they're still in AFib in the morning, they get a tea, no class, we cardiovert them, and they go home later that day. So, that is a very effective way of treating these patients. So, we don't keep AFib patients for long. I mean, we convert them, we control the rate. So T is a very important tool in your management of these patients. Also, your TE can also identify increased risk for left atrial thrombus. It's not only that you're going to see clots, but you're going to see features that suggest that this patient may form thrombus, such as the left atrial flow velocity. And in the recommendation, if the flow velocity is less than 4 centimeters per second, that's a very low flow. You want to flow above that, okay? So low flow, that means you're going to have some amount of stagnation and possible clot formation. Spontaneous atrial contrast, again. You see that, we call that smoke in echo terms, okay? This swirling suggests low flow and stagnation, and then you can also look at the atheroma, the plaques, okay? It's very interesting because 5 to 15% of the patients with AF, with atrial fibrillation, they were anticoagulated for a month and they're now coming for cardioversion. T before planned cardioversion reveals a clot in the left atrial appendage. So these are patients that you did to have a clot. You plan to do the cardioversion, but somehow you did a TE. 5 to 15% of them had clots. So, it's a significant number. So, and that is why we're very liberal with TE. If the patient missed one dose of their anticoagulant, we're going to TE them. One dose, just one dose. Okay, they need to be fully anticoagulated for about 3 weeks. But if they miss one dose, they're going to get TE. Okay, so we probably went a little bit over time, but discuss some very important concepts, and you have to understand these concepts. You have to understand the different terms that we use to describe atrial fibrillation, and the management. We haven't talked about the management yet, but our next series of lectures, we're going to talk about how do you